Welcome to our video on gynecomastia. Let's begin. In this section, we will begin by first discussing the definition of gynecomastia, then its pathophysiology, various etiologies, clinical features, approach to diagnosis, and finally, the management of this condition. Gynecomastia is defined as a benign proliferation of the glandular tissue of the male breast. When there is breast enlargement due to primarily fat deposition without concurrent proliferation of glandular tissue, it is termed pseudogynecomastia. Gynecomastia occurs mainly either due to increased estrogen production or decreased androgen production, decreased sensitivity to androgens due to receptor blockade, or excessive binding to proteins are also known mechanisms. The underlying concept is mainly due to the imbalance of available estrogen to testosterone ratio. When this ratio increases for any reason, this leads to stimulation of breast glandular tissue and consequently proliferation. The etiologies for gynecomastia can be divided into three categories, which are physiologic, pathologic, and idiopathic causes. Physiologic gynecomastia occurs with a trimodal distribution, meaning that it happens during the neonatal period, during puberty, and with old age. Neonatal gynecomastia can be seen in both genders and is a result of the transfer of maternal estrogen through the placenta. It affects both breasts and tends to self-resolve within weeks to months. Gynecomastia also occurs during puberty for adolescent boys, mainly due to transient imbalance in the estrogen-testosterone ratio, favoring estrogen. This is usually temporary and only reassurance is necessary as it usually resolves by age 17. Senile gynecomastia occurs in elderly males mainly due to age-related decreases in testosterone levels. There can also be pathologic causes for gynecomastia. Causes related to increase in estrogen levels can be from estrogen-secreting tumors such as Leydig or Sertoli cell tumors. They can also be caused by liver cirrhosis due to decreased estrogen metabolism, hyperthyroidism, or thyrotoxicosis and obesity. Other causes are related to decreased testosterone levels, which includes patients with hypogonadism. This can be seen in patients with Klinefelters, patients with chronic kidney disease, and also in patients with hyperprolactinemia. Pathological gynecomastia can also be caused by medications, especially those that disrupt the normal estrogen-testosterone balance. Drugs like spironolactone, ketoconazole, and cimetidine have been shown to cause gynecomastia. Additionally, exogenous androgen use can lead to gynecomastia due to peripheral aromatization to estradiol. Gynecomastia presents as a rubbery mass located concentric to the nipple areolar complex and is usually symmetrical. Gynecomastia arising during puberty for adolescent males is usually tender, which is in contrast to gynecomastia in other ages, where it rarely presents with pain. However, adults can also have some degree of pain associated with the breast enlargement, especially in the proliferative phase. Additionally, patients will exhibit the symptoms due to their underlying disease process causing gynecomastia. Symptoms observed can be due to a variety of causes such as liver disease, kidney disease, testicular neoplasms, and hyperthyroidism. This image shows a male patient with bilateral breast enlargement consistent with gynecomastia. Notice the area around and under the nipple areolar complex, which is visibly enlarged. Gynecomastia can be diagnosed using a combination of a thorough medical history, clinical examination, and a few lab tests to identify an underlying etiology. The physiologic causes of gynecomastia should also be considered. Details from history regarding medications used, including over-the-counter drugs, dietary supplements, herbal products, and exogenous hormonal supplementation should be collected. Other information from history regarding symptoms of liver disease, kidney disease, and hyperthyroidism should be explored. A family history of related conditions include genetic causes such as Klinefelters also can be elicited. The patient should also be examined for possible testicular or abdominal masses. Lab tests that can be done in order to identify an underlying cause include morning serum total testosterone, luteinizing hormone levels, human chorionic gonadotropin levels, estradiol concentration, liver, kidney, and thyroid function tests. Additionally, prolactin levels can also be ordered based on the history and clinical presentation. Ultrasound or mammography can be performed to visualize the glandular tissue and also to evaluate for a potential breast malignancy. A thorough evaluation must always be performed to identify an underlying etiology. Only after a complete evaluation has been performed can it be said that the patient has idiopathic gynecomastia. Now let us discuss the management of gynecomastia. Gynecomastia can be very distressing of a condition for many patients, and therapy aims not only at treating a possible underlying etiology, but also reducing patient discomfort. Patients who have physiologic gynecomastia, especially during the pubertal age, only require reassurance that this is a normal process, observation, and follow-up. Another important step in treating gynecomastia is to identify and stop an offending medication, as this can lead to regression of the breast tissue if done within the early proliferative phase. Regression is less likely to happen if gynecomastia has been present for more than a year due to fibrosis. Treatment of the underlying disease that is causing gynecomastia is also a mainstay of therapy, as it can lead to reversal in most cases, especially if the disease is in early phase. Patients who have not responded to the above conservative regimen, or pubertal boys with breast enlargement that is persistent, can be put on a trial of medication. For men and adolescent boys with persisting gynecomastia, selective estrogen receptor modulators such as tamoxifen has been shown to cause regression of breast tissue, even if the regression is not complete. Men who have hypogonadism as a cause for the gynecomastia should be treated with testosterone supplements. If the patients have not responded to medical therapy, the enlargement is causing significant distress, or in patients who have long-standing fibrotic disease, which is greater than 12 months, the patient can undergo surgical therapy. Surgery aims at resecting the glandular tissue and any associated adipose tissue via a periareolar incision. Let's now take a look at a practice question to finish up this lecture. A 25-year-old G1-P1 woman has given birth to a male infant via spontaneous vaginal delivery 2 hours ago. APGAR scores were 8 and 10 at 1 and 5 minutes, respectively. She had regular prenatal care without any prenatal complications. The vital signs of the neonate include a temperature of 37 degrees Celsius, blood pressure of 70/50, heart rate of 145, and respiratory rate of 50. The physical exam reveals bilateral breast enlargement. His mother is concerned about breast enlargement and asks if medical or surgical intervention is appropriate. Which of the following is the best next step in managing this patient? A. Tamoxifen, B. Anastrozole, C. Surgery in 6 months, or D. Parental reassurance. This 2-hour-old infant had normal APGAR scores of 8 and 10 at 1 and 5 minutes, respectively. His vital signs are appropriate for a neonate. The physical examination of the infant reveals the bilateral breast enlargement. His mother is concerned about breast enlargement and asks if medical or surgical intervention is appropriate. Neonatal gynecomastia is common in both genders and is caused by transplacental transfer of maternal estrogen during pregnancy. Nevertheless, it is temporary because the neonate is no longer exposed to maternal estrogen after birth. Therefore, neonatal gynecomastia does not require any medical or surgical intervention. Therefore, the correct answer is option D, parental reassurance. Here's a slide reminding us of the causes of physiologic gynecomastia. Pause the video and take a moment to consider this slide once more. Let's discuss why other options are incorrect. Options A, B, and C are incorrect because neither anti-estrogen therapy nor surgery is appropriate for neonatal gynecomastia. Again, gynecomastia in male and female newborns is a normal, transient phenomenon that requires only parental reassurance. And that concludes our lecture on gynecomastia.